Thank you guys so much for spending your afternoon, at least afternoon here in Phoenix. We're at lunchtime. I know a lot of folks are tuning in from all over the world, actually, so we're appreciative of all you guys tuning in. If you can comment on the Facebook feed exactly where you're coming from and what you do, that'd be greatly appreciated. We want to kind of see where you guys are coming from and what you're up to. Today, we have the pleasure of speaking with Dr. Melissa Cady. I've had the privilege of coming on her podcast for part of her Pain Out Loud website, and a very cool initiative and things she's doing over there that I'm going to let her talk about here in a second. This is the first time we've really had a physician on for any interviews. We've had physio researchers and we've had occupational therapists, and I'm excited to have a physician, especially in the pain medicine perspective. I don't think we've had really too many in general that I've seen out there outside of Melissa, and then Chris Caldwell is another DO that I know is doing some work in the similar things. But before we get into any more, I'd like, Melissa, do you mind introducing yourself to the folks?
Sure. Well, I'm in Austin, Texas, and I currently work as a board-certified anesthesiologist, but my actual second board certification is in pain medicine, and that was after completing a 1-year pain fellowship. And actually 2 days out of my fellowship, after substituting for another physician, who had wanted me to write over 50 scripts of opioids each day, I really got a really bad feeling in my pit of my stomach and seeing what everyone else was doing, and it didn't make a lot of sense to me. So that was 9 years ago, and here I am today, really kind of supporting my venture and really educating myself on different ways of dealing with pain. And ironically, I spend a lot of time around physical therapy conferences and other conferences, even functional medicine conferences, really because I felt like a lot of our medical training is very, very short-sighted and not really the complete picture. And most of those conferences are being funded by pharmaceuticals. And not that I don't think there's a time and a place for those things, but I felt like they just kept rehashing different ways of using the same drugs versus more additional tools. So I just have been going around the last 9 years trying to learn a lot, be a good student so that I could be a better teacher. And actually, ironically, someone at the gym told me I should write a book. I have a message, and I kind of laughed in his face. But then I decided, why not? And I put my passion on paper, and I released PAINDEMIC in 2016. And on the last page, I promised I would create a website called Pain Out Loud. So I was really committed to it because I had to. So I developed Pain Out Loud, which is really just a community of just sharing pain challengers, those who have found ways to improve their pain, and pain professionals like you, Mark, who are really trying to help those in a more holistic way and looking at the whole picture and the whole pain experience. And just getting those messages out. And this is constantly evolving. So my story takes many turns, but I will tell you that I've dealt with pain myself, and that's kind of what I talk about in the book too. But it kind of shifts your perspective and your personal experience.
Yeah, it's an interesting journey. I'm talking to folks who are in medicine. I've been able to work with quite a few pain physicians, and it's interesting when you talk about different levels of kind of traditional pain medicine education and materials that I talk to a lot of the guys about, or guys and gals, I should say, and pain science and pain neuroscience education and different things. And I know as a physio, and we've had this discussion before, in physio school, we tend to have that bias of biomedical and very tissue-driven ways of looking at pain. And we're more for a hands-on and an exercise approach. Of course, pain medicine looking maybe for an interventional approach to modulate that. And of course, those both have their place and both can be very effective. But as you alluded to, it does have its limitations. I'm curious, how is pain science and pain neuroscience and the explained pain movement and the pain revolution and all those different things out there, how do you feel that's greatest impacted you in your practice?
Well, honestly, I think that intuitively it made a lot of sense to me and this is how I look at the whole pain experience, and I'm a product of all these different teachers, of course. But pain is this protector. It's an experience it's constructed within the body, but there's some things that are not, you don't really think about. They just sometimes happen subconsciously. All of these different components are impacting your pain, and each person is unique. Each pain experience is unique. And to me, it's what is most relevant for that particular person. And it doesn't mean that all these other components are not important too. And that's where I think the hard work is in pain, is that you have to really understand their whole story, understand all these different components. Otherwise, you can be barking up the wrong tree. And I say that because nociception is how I was pretty much trained in the biomedical system. And just to give you a little bit more detail, when it comes to such things as epidural steroid injections, there's some people that actually have the words, they say, "I hope this fixes me." And I'm just like, I want to just cringe. And I'm the one of few physicians that sit there and educate people, because we're doing sedation for some pain procedures. That's where I'm working at this point. And so I feel so compelled to give them an educational piece so they have a better perspective if they're willing to hear it. You don't want to make them mad if they're not willing to hear it. But you can kind of tell the ones that are savvy and ask the question why, or want to understand more. But a lot of these procedures I was trained in, such as even medial branch blocks, never really made a lot of logical sense to me, because, okay, you're saying that these little, zygapophyseal joints or facet joints, these tiny little joints, the back part of the spine, that are apparently the ones that are lit up, causing the pain. Yes, we can have nociception from there. But if I'm putting numbing medicine in that area and I'm blocking that nociception, but no one's talking about the fact that the multifidus muscle and all the other overlying structures that actually get innervation to that from that area as well, from those nerves, no one's talking about that. It's completely fixated on this little joint, and this is the problem. And it never tells the patient why they have the problem. And I don't think we always have like an exact diagnosis to tell you that. Sometimes it's a matter of trialing out different healthy modalities and getting the patient active and their own thoughts, their movement, addressing their feelings, all these different things. And the fear, I mean, we could go on and on about the fear avoidance cycle. I personally deal with I consider my back problem like a susceptibility to back pain. I don't consider it like all the abnormalities of my MRI. Like, I don't refer to it that way. I just say, oh, my back's a little mad at me right now. I need to take care of myself better. So I actually have to self-talk with myself. And this whole pain neuroscience. I actually was doing this stuff before I learned a lot of this, David Butler and Lorimer Moseley and all these different, ways of trying to tell the story of how our pain is a story in the context of our life. So I find great value in it just for myself, but how you get society to buy into that when, what they see is just this concrete thing that fixes them. But to answer your question, the whole neuroscience of pain, it's always relevant. And anyone that says otherwise doesn't understand pain. And yeah, there you go.
Yeah. Yeah, it's science, really. Science is moving. It's always going to be moving, and we're learning more and more. And I think, we almost have a healthcare system that drags us into staying stationary with some of the incentives and all the things that kind of makes us more comfortable maybe to have a tissue we can label and do a procedure to, or a manipulation to, or, whatever. And it also gives us probably some comfort, I think, clinically to try to make something black and white that, as we've already discussed, it's extremely complex and things. I'm curious, because in physical therapy, we encounter resistance, because people come in with expectations from us that, it's going to be either be manipulated, maybe you dry needle, maybe you do different things. But I got to imagine you guys get it like times 10 of what we get as far as what patients' expectations are coming into your, intervention room or into your clinic for a consultation. I'm curious, how have you found, and you already talked about how some patients aren't ready for the message and they're not there, but I'm curious how you approach that with patients as far as to help them, maybe how you feel out if they're ready, and then how you might approach somebody to maybe move them towards a more adaptive view on their pain.
Well, let me first make it very clear that I don't work as a pain physician in a clinic.
Okay.
I work around pain physicians who utilize our anesthesia services predominantly in outpatient surgery centers. I do work out of a small hospital, but I do a lot of sedation for high volume pain practices. And so I'm not obligated in any shape or form by the typical anesthesiologist approach to just doing your sedation and keep going fast and keep it going. So I do this out of my own volition because I feel an internal obligation to make an impact in my own way because I love teaching. But I'd like to give you an example of a non-pain issue and how I in a short period of time, how I can give someone an aha moment. In particular, there was somebody that was getting a cataract surgery. Of course, these aren't like painful situations. I get that, but I think the approach is meeting the patient where they're at. And where I find that this person realized they were coming for their second eye. So they had an experience. So I think that experiential learning, I'm sure Adrian Lowe would, completely say the same thing there, is very important. That they had experienced that their right eye suddenly after a new cataract looked great. And then they came in when I saw them for the second eye. So they already had conviction that this was of great value and that they could handle going through the procedure. But what was most important was that she didn't realize how much better she could see. You can make an analogy to how much better you could feel or less pain. But she had no idea how insidious this process was for her right eye. And then suddenly there was a change, something revealed that, man, it really was getting bad and I didn't realize it. So she came in the second one with less fear. She knew what to expect. But she also realized how things can change so slowly that you don't realize that things can be harmful or getting worse for you. So she just happened to be a smoker. So right after this moment, I was like, oh, this is my end time. And so I was like, it's amazing how things can change so slowly. You don't realize that things are getting worse and that you could be so much better. And she's like, yeah. I was like, well, it's kind of like you're smoking. And she just, the moment her lights went on and she's like, okay, you got me there. Okay, I understand now. So that was just like one of those where I did it right. I have plenty of times where I do it wrong, where you try to feed people when they're not hungry and it doesn't work. Yeah. That's why you need a relationship.
Yeah, no, I think everybody who's listening and who will be listening can relate to that. Sometimes it doesn't work. And Adrian Lowe will say it. There's stories you hear about Lorimer Moseley and some of his, reactions that some patients have had with him. And these are supposedly, the experts of all experts in it. But that's, again, to me, goes back to, we're dealing with something that is much more powerfully and complexly modulated than what we're always going to be able to control within one treatment session, within one, encounter with that patient. So it's interesting to see your experience as well, as far as those ones are what makes you so excited and so, gung-ho to just see if you can change that one person out of maybe a few failures here and there, and then they start building up, you can make a change. What would you say? Because I think so much of this is cultural, and there's biomedical culture that I think we both practice in. What do you think would be the main things that would be helpful to get? Because we're fighting the battles here to get this more on the front lines of physical therapy practice. I'm curious what you think would be maybe some positive steps to help that become more of a part of medical education. And then when you get into anesthesiology and these fellowships, pain medicine fellowships, how that could better be incorporated. I know it's a massive task, and we're going to take the rosy glass approach and say we're going to be able to change this stuff because it's a lot of barriers to it. But what would you think would be a good way to help that out?
Well, let me just first state, how things are the most difficult. And what we just spoke about was, I just spoke about someone who had a belief system. And there's an element called, or phenomenon called, cognitive dissonance. And once you have a certain belief in something and someone tries to almost destabilize your sense of this is the normal, or this is my belief, or question you, it's extremely anxiety provoking and very difficult. In fact, certain physicians and surgeons that have realized the neuroscience of pain and recognized the limitations of their initial training, we typically go through a very stressful, anxiety-driven phenomenon within ourselves of coming to terms with reshifting our beliefs. So I think it's harder to go uphill, and work against the current beliefs. I really think the most effective way is to embed it within the belief systems at the beginning of the education process, when we're most, I don't want to say gullible, but the most impressionable. And if this becomes part of the expectation of the complexities of the body, I mean, you looking at clinicians who are not taking care of themselves, and I'm talking about not just physicians, but we have been ingrained to be tough cookies in a way, and you're not going to be good or successful unless or you're not going to be successful unless you just kind of go through it all without complaining and being tough. I mean, if you have any complaints, you're actually kind of frowned upon, and it just doesn't bode well for your success within the medical system. So there is a certain level of tolerance, and I think to a point where we don't even recognize what anxiety and stress and all, it's just normalized. And so if we're doing that to ourselves and we're not even recognizing our own these intangibles, then how are we going to be able to recognize it and realize the importance of them in our patients or our clients? So I think we have to have, I mean, comes down to the infrastructure of our training from the get-go. I think it's just really hard to change. I haven't really gone into that, trying to completely change that. But I think at some point, and there's some other physicians I've been talking to about, we need to change the training of people going into the medical system, because pain is everywhere. And if we don't have this basic foundation and understanding, then we're constantly going to be working around this or butting heads against people all the time about the belief systems that they have. So I just think it's way more work than we should have. If the belief systems were the other way around, we wouldn't have the same, pushback.
Yeah. I mean, that's, you hit it on the head. I think reflecting back to the International Association for the Study of Pain's conference in Boston, they had a lunch workshop about curricular redesign to help, medical training. It focused more on medical school and medical training just because that was more the audience of that talk. But it was interesting that they talked about how in the medical boards, I think it was 20%, I might be wrong, give or take, were actually questions related to pain, but it was on one domain on it. It was how to identify it. And they went, but how do you, looking at the mechanisms, the social complexities, the psychosocial, all that stuff, there was minimal to none of that. And especially how do you help those folks? It was just like, maybe you can identify a complex regional pain syndrome case, but it doesn't give you any of the background of what goes into that and any of the complex, overlays of, cognitions, beliefs, all the things that you speak of with that. And I think one thing that kind of piggybacks a little bit with that is that whole backfire effect. And you brought up cognitive dissonance, which is a great thing. You guys should look that up as a term, because it really, when you try to introduce new information to somebody and they're not ready to hear it, or it puts in conflict too much with their going narrative that gives them comfort of what they're doing and why they're doing it, and that it's maybe the best way to do it in their mind at that time. And trust me, I'm sure Melissa's had some cognitive dissonance. When I was first introduced to pain neuroscience in the midst of my manual therapy, zest, and that was my definition of who I was, it was very threatening to me. So I'm curious, and suppose to get into more stories of that stuff. I'm curious, what kind of things are you up to? And I know we've talked offline here and also on your podcast what kind of things and movements are you up to help? I know you're doing it on a patient level, but what other things are you up to on maybe a physician interprofessional level to help kind of deal with delivering that message to hopefully help some folks maybe adjust their belief systems a little bit?
Sure. Well, I wanted to make one comment off of what you had just said with cognitive dissonance. I've realized that, and you just made me think about this, if people stumble on the information themselves without it being forced on them, there's a certain level of discovery. It's like almost like because you discovered it, it's more palatable and easier to take in. As long as, if it's a clinician that comes across it, just stumbles in and is just wowed by the information, obviously you don't want to have if there's a financial incentive not to utilize that information, then that it also works against them. But it all depends on, where's their priority? Is it, I hate to say this, but pocket advocate or a patient advocate? Which one's going to, which are you going to lean towards the most? It's a term I use in the book all the time because that's always, we're all battling with that if we have our own business, because you have to keep the roof above your head. So anyway, that I just had to mention, because sometimes if people just come across it, it's almost easier to accept that information versus just powering it into somebody. As far as the things that I'm doing out there, I've got a few things rolling right now just from a social media standpoint. Believe it or not, I've rewritten the lyrics to Baby Got Back. It's called Baby Got Back Better. And very much focused on neuroplasticity, even used the word in there at some point. Really encouraging people to not fear things and be healthier at how they approach things. So that'll come out over the next month out there just to share with the world. I don't make any money off that. Obviously, it shares who I am and what I'm doing. But I'm also putting together what's called the PAINDEMIC Summit, a call to harms, and it's 3 orthopedic surgeons, including Dr. David Hanscom, which a lot of people might be familiar with. Also 2 other pain physicians as well. And so really it's 3 pain docs and 3 orthopedic surgeons, and we're talking about the risks and benefits and real discussions about how the neuroscience of pain is changing how we're doing our practice, or for some, they're actually retiring from their original intention to do surgery. So pretty profound, and that'll be free to the public first week of December. I'll be sending a link out in the next couple of weeks so people can sign up for that. I also have three presentations I'll be doing in January with Mark Milligan at the CSM in Washington, D.C. So we'll be talking about the non-pharmacologic logic of treating pain. And then in March, I will be presenting, or I'll be part of a collective presentation in Denver at the Align conference. And then also I'll be presenting, I'm going to be dragging along a friend of mine who's a nurse who also has complex regional pain syndrome. He and I are going to present the power of stories, or pain stories. And that'll be presented in Phoenix, I guess division of the American Physical Therapy Association out there. Yep. So I've got a few different ways, and excuse me, that I'm actually going to be presenting and trying to just get these messages out. But honestly, I feel like I'm talking to a lot of like-minded people for part of the crowd. But that's like my scheduled events so far.
No, I'm looking forward to it. I'm in Phoenix, as you know, and I'll be at that conference presenting as well. So hopefully, we'll definitely chat, and I'm excited for that conference. For those of you guys who are here in the Arizona area or even in the region, that's worthwhile maybe considering making a trip down to Phoenix, because we're going to have some great speakers. We're going to have some patients talking. We're going to have Melissa, myself, and a bunch of other great clinicians and folks that are going to be hopefully helping the narrative around pain in Arizona. And we're going to hopefully get some other, maybe other groups besides just physical therapists to be able to come to that conference. But that's going to be great. It sounds like you're doing some amazing things, and we greatly appreciate what you're doing within the physical therapy profession. I think there tends to be this lack of multidisciplinary collaborative efforts, although, you read the research and there's so much discussions on how we should be working together. And I recognize too, there's so much systemic barriers to that. And I know physicians who would love to have time to hang out with a PT or speak or have a collaborative. For a lot of docs, and you can probably attest to this, the work life of a physician really makes it hard for them to keep their head above water, to manage their own patient load, let alone have communications with area clinicians there. But I'm curious, how do you balance that as a physician? And maybe there's some times where it's insurmountable, because there was this initial part of me like, man, I'm so mad at physicians. Like, they don't spend time to hear the story. Then I actually talked to physicians and heard the stories of what they have to go through in a normal workday. And it made a lot like, man, they don't really get put in a situation to succeed. I'm curious what your experience with that is, and maybe what you see as maybe a way, solve healthcare in 5 minutes with a discussion here. That's obviously a little bit rosy thinking, but curious what your experience is as a physician, what you see out there with your fellow physicians, because I think we're too quick to bang on physicians over maybe a lack of communication and stuff. I'm curious what your thoughts are on that, maybe how we can best help physicians who are maybe struggling to have the moment to tell the story with a patient or communicate with a physio. What are your thoughts there?
So I'd like to pretty much emphasize, make sure you do some reading on neuroscience of pain, and pretend that the physicians are your pain patients and that mental anguish is another form of pain, and that the story is really important, and that understanding the nuances will help you appreciate, just like you did, Mark.
Mm-hmm.
And I think that goes for all of us in life, whether you're dealing with the medical system or not. I think that we're quick to judge just by the nature of being human, I think. And we know our world better than the world in front of us, that we only see the exterior. So as far as how I balance things, I think I knew coming right out of my pain fellowship. Granted, I had just gone through a divorce year before. This is personal stuff, but I think I was at that place in my life where I realized that I wasn't practicing good self-care. And I jumped out of all of my training with an immediate need to not do 5 days a week. And for me, I never intended to do 5 days a week, because it wasn't that I said I don't want 5 days a week. I just wanted to be happier in my life. So I got used to living off of 3 days a week of income. And so for me, it was about being honest with what I really needed, and giving myself the time to explore, which has turned out to be 9 years of a lot of all these things I was talking about. I also happen to have a very supportive husband that realizes that my deepest passion and mission really is not about just putting people to sleep and doing blocks to help out with acute pain, which is great. But I feel this deeper sense of purpose to make a difference and get better messages out there so that people can feel empowered and not fearful. And so what keeps me going, fortunately, as an anesthesiologist, I get paid a decent salary, even though I work 4 days a week. At this point, I do 4 days. I got benefits that way, but that's my max, is 4 days a week. And so it allows me to have the income to travel and go to conferences. So I use it for what, I try to do good work when I'm doing that, and I take pride in my work, but I feel a deeper sense of purpose in the pain world because there's still much to learn. And I feel like so many people feel like it's painful to deal with pain patients, when I don't think it should be that way. And so for me, I think you have to realize too that most of these physicians out there are not typically anesthesiologists where you're contracted work, where you just show up, do your work, go home. Most of these physicians have to deal with, if they're doing surgery, then they have a clinic, and then they have to deal with the overhead. And that's, I think, predominantly why we have a better income comparison to some of these surgeons and other primary care, is that we don't have the overhead concerns that they do, other than, a little bit of billing here or there, but we don't have the infrastructure typically, unless you're a big group. So, but as an independent, you can go do work and you're done. You don't have to worry about running a clinic. So no one really talks about that, but I think it's quite relevant because it's another stress. So, I think it goes for anything in life. What keeps me balanced? I don't think there's anything really perfectly balanced. I think it's a matter of always reevaluating where things are, need more work. And it's there's multiple things you're trying to balance, but it's never a perfect balance. There's some things that'll take precedence over other things at times. But yeah, learning about neuroscience helps me take care of myself better.
It's interesting because you talk to a lot of people who've gotten into pain science and stuff, and they often can like relate it back to a personal story of difficulties and stressors they've had that really had them take that more personal, introspective look of like self-care. I think I shared the story with you on your podcast about my catastrophizing episode with a herniated disc and how my wife was rolling her eyes at me because I'm doing everything that I tell patients not to do when I had this, because it was just in a period of time in life where I was in the middle of moving to Arizona from Michigan, all these different things, and just amazing how that human side comes out. But it almost, to me, almost resonated more as far as now I can kind of see from that patient's perspective, just those natural visceral responses that, we as human beings go through when we're dealing with pain and scary stuff, as in threatening pain that threatens a move or whatever it threatens for us in our life. I'm curious, what are your thoughts, and where do you feel like the humanity part of healthcare? One of my big things I always say is like we've stripped the humanity from healthcare because we got docs who are stuck in front of computers who have to check boxes and are enslaved to an EMR, and we're kind of there too as a PT. What do you think? Where do you think humanities fit currently, maybe in healthcare, and where do you think they, in your perfect world, where would you like to see like that human side of healthcare come out in the future?
The first word that popped in my head is humility. I think there's a lot of pervasive social media type of this projection of perfection and these ideas that, that it doesn't really describe necessarily always the feelings and what people are going through. It's just always this projected image of this final result. And I think we have to have a conversation and be able to talk about these feelings. I've always been pretty comfortable whenever I can identify the emotions. It's not always easy. Sometimes you just feel something, you don't know where it's coming from or what it means. And I really think that the medical training, at least from becoming a physician, I don't feel like it really helps you understand. I think it kind of strips some of those feelings away because you have to almost ignore them to get through your day. And I can't recall how many times I've had to actually, without any guidance from anybody else, had to deal with withdrawing care, talking to families and their patients are dying, their family members are dying, and no one prepares you for that. And the humanity of the training should be there to discuss what feelings you're going through with having to deal with other people's emotions that they're dealing in front of you. And it kind of goes back to this whole thing about what I was saying earlier. It's just, if we don't have a sense of the intangibles within ourselves, how are we going to help people with the intangibles within them, which, oh, by the way, happen to influence your pain? So, that's just my feeling, is that the humanities should probably be a component of the whole medical, and they can interdigitate it with, various courses and stuff, but that should be part of, the whole training. Too many people are uncomfortable talking about their feelings, and people get shamed for having them. And it's like you're being shamed for being human. And I hear these stories about even physicians who are just letting, medical boards know that they feel overstressed and taxed by the system, and they get their medical license held from them. And it's just, when have we lost the idea that, or this reality that we're all human? And unfortunately, when you have clinicians who are overburdened and not taking care of themselves, burnt out, and they're trying to help someone collectively with their experience of pain, that's not a very therapeutic relationship. And if we don't get that, we're failing our society in really treating pain. So we have to really elevate how we're treating everyone in the process, and blaming, there's always gonna be bad apples, but you can't blame just clinicians. It's the whole process and both sides of the story. So I think we need to be more supportive and help people and not shame them for feelings or struggles, and just elevate them and help them out.
Yeah, I think that's a great point you bring up, and that we don't even acknowledge our own emotions and our own feelings and some of our own biases and things that we carry, or some of the struggles that we bear. And it's you almost get programmed to kind of, especially, I taught to new grads. I'm blessed where I see patients every hour, half hour. I don't have this massive productivity requirement that a lot of PTs out there have. And it's like, it's almost where they're burning out. They're like just grabbing all these emotions and holstering them because, they just got to get through a day and get through a shift. And how do they have any opening to take on any of these emotions and these human issues that are coming through their door, one from not just a time perspective, but just from a human perspective. It's crazy the expectations we put on physicians and new clinicians who are just, you almost put them in a no-win situation to be able to do the things, all these complexities that you nicely pointed out that we're hiding are the exact things that we should be talking about, because we know when we look at research, the bigger things that predict chronicity and people that go on to have chronic pain are those, in fact, issues that people are holstering up. It would sure make sense that we start being comfortable talking about them. Did you have something you wanted to add?
Yeah, you made me think of, there's several professionals that by the nature of what I'm doing with Pain Out Loud and meeting so many great people, and even other people outside of Pain Out Loud, I've had several professionals that have felt like they've been on an island and feel like they're the only ones that feel that way. And this sounds so reminiscent of the pain patient or anybody else that's struggling with some mental health issues or whatever the case may be. But I will tell you, I've actually had professionals that I spoke with that basically I was just open about talking about my feelings and that validating them and telling them that this is normal, that the way you're feeling, and that there are problems and that they need to be better. And yes, we all have to find a solution together, but they've told me afterwards how much better they felt I didn't solve the problem, but they just let it out. Whether you want to do it through expressive writing with your own tension, anxiety, and stress, or you just talk to somebody. And this was like even over the phone. I wouldn't, give them a hug. It's just getting it out. And they were so thankful that they talked to me for that 30 minutes to an hour. And I was getting paid for that. We're just talking, about the struggles. And that person, even to this day, a year later, feels like she has more hope and doesn't feel alone.
Maybe this is your next niche, like the virtual shoulder to lean on when folks are getting burned out. I read a bit on the physician side of things, and thankfully I have, because it's gained a lot of perspective I didn't have of all those tough things that the physician population go. And then you see some of the suicide rates and some of this crazy stuff that's going on. And I fear that our profession's headed in similar directions with what we're doing to young clinicians and pushing them beyond, human limits. You can only do so much and take so much on board before something breaks. And it's sad that we've gotten to that point that it's almost inconvenient to be a human. But the interesting thing, and you've already alluded to this, is like that's exactly what we do with pain patients. We validate, we listen. You're not alone. There's hope. There's another way. And you see like patients, we just had a patient the other day who I just said, man, this has been pretty horrible journey and all these things, talked to and listened. And you should just see her complete demeanor and how she moved on and off the table without doing anything physical to her was like a night and day. And the students like, oh my God. I was like, that is what humanity and pain science and all this stuff, why it matters. It's like, I didn't touch her, but we would get fired up if I did a manual therapy, a manip with that. And the power of humanity, I think we've snuffed it out, and it's just, sometimes it's an inconvenience to our productivity and stuff. But
yeah, you made me think, I'm sorry.
Go ahead.
No, you just made me think of several patients. I forgot to tell you this, that I've literally validated their circumstance and even kind of like simplified the sense of anxiety and fear and the pain that they've been experiencing. And this is like, I'm supposed to be doing anesthesia or sedation for them. And I can't tell how many people just start tears just flowing out of them. And they just suddenly feel like heard and that somebody gets them. And, I'm not experiencing what they are, but there's just so many people that go through feeling like nobody's really listening or believing them and making them feel bad for whatever reasons.
And I would argue, I don't know what your thoughts are, but those are some of the most rewarding interactions that I've ever had in healthcare, is just like, whether it be a patient or a colleague. That stuff is what makes me want to do this stuff more. It makes me like, I want to, the fact that, just listening and feeling heard, which you think would be a prerequisite of healthcare, can make such a profound difference for a clinician and a patient, just to me is partly sad, but then partly motivating. Let's go out and listen and validate some of the stuff that these people are going through.
Absolutely.
To kind of go off on a little bit of a different topic, I always like to because we had a lot of clinicians here, massage therapists, physical therapists, we have chiropractors, myotherapists, we have folks from all over the world. But I'm just curious, we have our own culture here in the US as far as healthcare, but the one thing I think that none of us can argue with is that there is not one profession that's going to fix the epidemic that is pain. It's not a one size fits all approach. I'm curious, from your perspective and your experience as a physician, where you think that all of us can work together. Maybe a physician and another professional like a PT, a chiropractor, or a massage therapist. How do we you mentioned humility, and I think sometimes we look up or down at different people and don't see things on an even playing field. But I'm curious what your thoughts are on how we can all kind of work together in the same team to move things forward to just help people.
Well, that's the $1 million question, right? Well, I think that there's there's different levels of it. Obviously, the system reinforces the way we're doing things right now. It's very focused on paying for interventions. I can make tons more money if I was just doing interventional pain, to be quite honest. That's not what drives me. So, all of us have to make a living, but I need to feel good about what I'm doing. And like you said, massage therapy, no one particular profession is going to have the answers to everything. I call it there's no painacea. There's just like multiple things affect our pain, there's multiple people that can affect our pain. And I think if we can get the neuroscience of pain introduced to everybody, so that when maybe they love using their hands, and there's nothing wrong with that, but if they put it in the context of, I'm able to do this for you, this is how it could affect your pain, whether I'm right or wrong, you never know till afterwards sometimes. But here's the canvas of how your pain can be interpreted or constructed, and that this is where I can impact it. But if you neglect all these other areas, then I'm only able to affect it to a certain extent. And so I think if every profession kind of pulled in this neuroscience of pain, this holistic approach, and really the reality is the whole system is always working together. So we shouldn't work against each other, and and we shouldn't let the systems work against each other either within the person having the pain. So to answer your question, I think it always comes down to education, because that's dictating our behavior, but it's also the financial. So I think we all have to work really hard at dealing with more patient outcomes versus treating, because all you see is these volume practices that churn people in and out. At some point, that's going to break. I really do believe things are going to get a lot worse before they get better from a financial standpoint, because we're even in anesthesia and surgery, we're going so fast. And you look at the reimbursement always seeming to go down. It's not very often that salaries don't go up with inflation, but physicians, we typically don't have a rise in our salaries. In fact, if anything, it might go down, which is very unusual compared to the rest of the world. But in the medical system, the way this whole game is played amongst insurance companies, this lack of transparency, people don't know what they're really having paid or how much things cost. So I think we need some transparency in things, and be more focused on outcomes versus just per procedure, because at some point you can only do more, some people are doing like 25, 30 injections in 4 hours. And there's a point where you can't go any faster. Like you'd have to skip putting the needle in somebody. Like, there's a point where you won't, if the reimbursement keeps going down lower and you keep going up on your procedures, there's a point where you're not going to make a profit at all. So if they don't get paid for doing those things wouldn't happen, or if they didn't get paid enough. So unfortunately, most of these pain procedures don't have a lot of strong evidence, just to give to anybody. So, the question is, if they're not really effective and then you don't get paid for them, how many pain physicians will still be in business? Unless you're doing it in a different way as far as your business.
Yeah. No, I
know
think
that's a kind of a bleak look, but
it's true though. I think, money drives really the ship. And if we don't change some of the incentives out there, I don't think we change any of the behaviors. And, I agree 100% with what you're saying. I've, spoke to other folks in the pain medicine world, and they're, in a pretty tough situation. And, I can't even imagine doing that many injections. That's like, in that short a period of time, that's just, to me, it almost raises so much risk too, as these guys are going so fast. When does it become unsafe, I guess, as far as doing that? And you probably know more about that than me, but we do have so many things that are working up against, best practice and that stuff. And I agree with you. I think it's going to break eventually to where, the cream can hopefully rise to the top, that are, showing some incentive for outcomes and best practice and care and all that stuff. To respect everybody's time here at lunchtime, and because I have to get back to clinic, of course, I'm curious, any closing thoughts or things you want to mention? Definitely, we'd love to know where we can find you online and how we can maybe get in touch with you. Maybe you'll be kind enough to share links to the summit you got coming up on our page, or I can definitely pass them on to folks. But
Sure.
I'd love to hear any closing thoughts you have.
Well, as far as learning about even if you want to learn about anesthesia, I even did a 19-minute video about elective anesthesia. All of my activities are at challengedoctor.com, just because everyone misspells my last name. So it is melissacady.com, but it's really challengedoctor.com. But you can go to Pain Out Loud through there, but Pain Out Loud is where the community is, and any of my events or activities that are very pain specific will be there. But I think I just want to close with just saying that I think I'm very, very grateful and appreciative of so much support from non-physicians or physical therapists, because when I felt like I was on that island by myself and very frustrated, I did feel alone. And when I would express some of my concerns or would go to conferences, there was such a sense of pulling me in and just being really supportive. And we all need that every once in a while. And sometimes if you don't get it from your own colleagues because they don't really understand pain, sometimes you need to find your support in different places. And so I just wanted to thank all the physical therapists that have always been so positive and uplifting and encouraging me, because that's probably why I'm still doing what I'm doing right now.
No, it's talking to folks like you and talking to folks like others in other professions, the Bronnie Thompsons in occupational therapy, Lisa Crawford's, the other folks around that I think definitely makes me think that there is hope as far as going forward, and you can kind of lean on each other when we're all kind of fighting the good fight in our respective healthcare arenas, I guess you'd say. So with that said, I can't thank you enough for your time today, Melissa. I know you're extremely busy and you got some awesome things going on, and we're all rooting for you as far as to keep pushing the good message forward, and we're all on board to help you. What we'll definitely do is I'll put the links to challengedoctor.com and painoutloud.com down below. Definitely check that stuff out. It's a great resource. She's got amazing interviews and different folks that are on there that I think you'll gain some amazing perspective from. But I really would just want to again say thank you so much, Melissa, and I hope you have a great rest of your day.
Thank you. I appreciate it.
All right. Bye-bye.
Bye-bye.